Welcome, everyone. Thank you for being here live. We'll be starting very shortly, just a matter of minutes. Feel free to settle in, make yourself comfortable. Make sure you have in front of you what you need to stay comfortable over these next couple of hours. And just checking the chat box myself. Yeah, good morning. There, I needed to open my chat box to see what you were saying. I was looking in the wrong place. Good morning, everyone. Coming in from all over. Good morning, good morning. Lovely to have you here. Welcome back. Thank you for joining us bright and early. We'll be making a start soon, just a couple of minutes away. So as a reminder, our presenters won't be able to see your comments or your questions, but feel free to chat with us in the chat and we will pass on questions to our presenters when it's time. Oh, I can see some more people have joined us. Welcome, everyone. Come on into the meeting. Get comfy, make yourself settled and comfortable. Make sure you're hydrated, have some water in front of you, have a stretch. We're in for a wonderful session this morning, that's for sure. Wet weather in Sydney, is it? Okay, take care, everyone. A question. Any chance we can print slides? Where did that question go? Any chance we can print slides so we can take notes on them directly? Yeah, you will find the handouts are in the supporter directory. So you can go to the supporter directory and look under the company or organization of the presenter. So for instance, for Amy's first presentation, that is under Mother Bloom or Neuro Bloom. And for Gillian's presentation, that is under the Sensitive Midwife. So you will find the handouts are sitting there for you waiting. Okay. Good morning, everyone. Welcome. Come on into the space. We'll be starting very shortly. Just another moment to make yourself comfortable before we start. And for those who are joining us live, feel free to pop something in the chat box, say hello to us. Let us know where you're zooming in from. Just as we make a start in a moment. All right, well, welcome everyone. Let's make a start officially. Welcome back, everyone. If you weren't here yesterday, hello. I'm Dr. Bronwyn Lee. I am your conference curator and your host. I'm also the director of the Perinatal Training Centre. It's my pleasure to welcome you to this very special event. Thank you for joining us in this space. Settle in. We have a wonderful program for you today. But before we start, a reminder. Please do go gently. Please do look after yourself through these sessions today. As we journey together, we know that the content might be activating for those of you with lived experience. We know this, so please go gently. And my invitation to you is to put your hand on your heart at the times that you feel wobbly and hold your hand there so that you feel the warmth and know that you are not alone in your wobbly feelings, whatever they may be, in your sadness, in your grief, in your rage, whatever it is that's coming up for you. And do know that you are not alone in that. Also know that we are on a path to doing things differently and to making a difference. And that's why we are all here. So thank you for joining us here. A couple of reminders too that if you are live and looking for the handouts, they are in the supporter directory. You will find them listed under the accompanying organisation of the speaker. So for this morning's talk, we have Amy Pember's talk, and that handout will be under Mother Bloom or Neuro Bloom, and Gillian's handout will be under the sensitive midwife. So you can find the handouts there. That's in the supporter directory. All right, so we are on day 2 of our conference and we have 2 sessions for you today. Let's have a look at those. Okay, by way of reminder, here is our conference program. Today we have sessions 2 and 3 yesterday. This is where we were looking at pregnancy, labour and birth. Today we're looking at early postpartum parenting and infant feeding. Then we'll have a little break so that you can decompress and re-energise, and then we'll come back for dads and couples. This is our session 2, our first session for today. And in this session, we'll hear from 2 presenters, Amy Pember talking about early postpartum period and Gillian Ryan talking about infant feeding. First up, we have Amy Pember. Amy is an ADHD perinatal psychologist from the beautiful southwest region of Busselton in WA. Her professional focus on perinatal and infant mental health has been deeply shaped by her own lived experience of the transition to motherhood, particularly that significant adjustment from being a working professional to becoming a stay-at-home mother. Understanding this journey through her lens of neurodivergence has given her unique insight into the experiences of autistic and ADHD parents in the perinatal period. Today, Amy is speaking with us about supporting autistic and ADHD parents in the postpartum period. Amy, welcome.
Hi, everyone. I'm just taking a moment to settle. I'm so grateful that I got to witness Sarah Harrell doing that yesterday because that made it feel okay for me to do the same. And I'm sharing that with you to show that we are always learning how to show up as late identified neurodivergent people. Okay. There we go. So welcome, everyone. Today we're entering a tender, powerful space, the early postpartum period for autistic and ADHD parents. This time is often rich with love and vulnerability, but you can also bring unique challenges that are misunderstood or unsupported. My goal is to explore with you how we, as clinicians, can meet parents in that tender space with affirmation, presence, and respect. So first, I would just like to take a moment to acknowledge and pay respect to the people of the Noongar Nation on Wadandi Budja, the land on which I present from today. I also acknowledge the traditional custodians and elders of the various lands across our nation from where you are all located. I would like to share my support for all First Nations families to have access to birthing on country. Sovereignty was never ceded. As we all know, stories from the perinatal space can be hard to hear and sometimes hard to hold. So many of us will have our own lived experiences that can become activated. Perinatal work is deeply personal work. So I encourage you to take care of yourself and listen to your heart, mind, and your body today. If you need to take a break from the content, please do. You'll have access to the recording to watch at a later date. And so with this in mind, I'd like to just give an acknowledgement of diversity. So I'm committed to creating an inclusive and safe space for everyone. I value people of all abilities, bodies, genders, sexualities, cultures, ages, neurotypes, and backgrounds. And that includes all of you. So follow your needs, use strategies and supports freely. And I acknowledge that while I present here as a professional with a disability, I'm also privileged in many other ways. And I'm aiming to use this privilege to give voice to others. Neurodiversity affirming practice does not exist without intersectionality. And I just want to give a personal acknowledgement to gender diverse people in the audience and to gender diverse families, and particularly our trans colleagues and trans parents. It's not a safe space for the trans community at the moment, and I want to just draw your attention to that. Just waiting for the slides to change. It's probably going to jump ahead too far, so if it does, I'll send it back. Just a little comment about the legal stuff. This isn't fun to talk about, but it's very serious to make these terms of use and copyright explicit. So just acknowledging that, you know, I've spent a lot of time and money and executive functioning and emotion regulation developing this presentation and collating like my clinical knowledge and my skills. And I'm so happy to be sharing it with you today. And I would love you to take it and to use this information to support your practice and your learning. Please don't share it with people that are not attending today. So a little about me. I'd like to point out to you that the way that I present today as an AudieHD perinatal psych is very different to how I present in other contexts, like when I'm scootering with my kids or when I attend school pickup. So remember that I am presenting to you about my special interests, which makes it easier for me to connect despite the social communication differences. My dopamine will also be firing throughout because this is fun and interesting, exciting, and of course a challenge. Capacity fluctuates though. So this afternoon, I will probably struggle to talk to my family. And as you can see, what I've tried to show you here is just a little bit about like my identity, my intersectional identities, how I show up in the community, the community organisations that I volunteer time for. There's my special interest. You'll notice that that's very much around psychology and a lot of what I do for work. And so I'm learning how to play because believe it or not, even when you're working and love learning in your special interests, the brain gets tired, and I need to learn how to put that down and just show up and do things just for the fun of it. Oh, gone the wrong way. There we go. The session outline. Today I'm going to talk to you about the tender space, points of vulnerability, but I'm going to actually use a case study that I've totally created. It's not based on any one client, to talk you through that, because I think it's in the case studies that we learn how to make sense of what we see with our clients. I am always someone that aims extremely high. This is all of the things that I wanted to kind of touch on today. But obviously, depending on your experience and your exposure to neuroaffirming practice, you may take away bits of this. And the main thing that I want you to take away today is to start reflecting on your clinical practice and your therapeutic relationship with autistic and ADHD parents. So, we know that the early postpartum period is a time of both identity transition and relational unfolding. But what do I mean by the tender space between? The tender space is the relational space between parent and infant, a co-created zone where connection, identity, and emotional safety begins to take shape. In the early postpartum, parent and baby meet in a space of profound vulnerability and untapped capacity. Neither arrives fully formed. Both are becoming together. It is in this delicate rhythm of their relationship that each begins to discover who they are to each other, and how to simply be. I invite you to reflect. What have you witnessed in this space? And what have you felt in it? So, for autistic and ADHD parents, the early postpartum period can be an especially vulnerable time due to heightened sensory, emotional, and cognitive overwhelm. Many navigate this transition without a clear internal script or external models that have affirmed neurodivergent ways of parenting. Without understanding their unique needs or seeing that their experiences are reflected in mainstream parenting narratives, they may feel isolated, dysregulated, or inadequate. This lack of affirmation can disrupt identity formation and make it harder to access co-regulation and connection in the parent-infant relationship. So what happens when the tender space frays? When neurodivergent parents are unsupported, overwhelmed, or misunderstood, it can disrupt their ability to feel safe and regulated in the parent-infant relationship. These challenges can limit access to co-regulation, attunement, and responsive connection within the tender space. The relational space may become shaped by stress, shame, or disconnection, instead of the safety, rhythm, and mutual discovery that we would like them to experience. So supporting the parent's nervous system and affirming their identity helps protect and nurture this relational space for both parent and the baby. I want to say I love this photo because it's hard to find a photo of a dad learning to baby wear. So neurodiversity affirming postpartum care is not optional, it is essential. Neuronormative standards of parenting are not just unhelpful for autistic and ADHD parents, they are unattainable. When services enforce these standards, they cause harm, undermining the parent's confidence, dysregulating the nervous system, and disrupting the parent-infant bond. Without affirming care, we risk compounding trauma. We are not preventing it. We must replace outdated norms with approaches that honour neurodivergent ways of sensing, thinking, relating, and parenting. So, unpacking vulnerabilities in the postpartum for autistic and ADHD parents. First, the social and communication differences. So, to understand social and communication differences, we need to come back to defining culture. Culture refers to the shared values, norms, communication styles, and ways of being that shape how people relate to the world and to each other. Autistic and ADHD people experience, interpret, and respond to the world differently, forming distinct neurodivergent cultures with unique rhythms, sensory needs, social cues, and relational patterns that are often misunderstood or even devalued in neurotypical settings. If a family's parenting practices reflected a culture different from your own, would you correct them? Or would you pause to understand the values and the context behind them? Why is it any different for a neurodivergent family? So, as you reflect on this slide, note that the vulnerabilities here are actually reflecting the double empathy problem. It's a cultural and language miscommunication between the perinatal care providers and the parent. We are in the position of power, so it's our responsibility to adapt our practice to support a parent's needs. Executive functioning differences. Executive functioning challenges can deeply impact everyday parenting tasks, feeding, nappy changes, appointments. It's not about not knowing what to do, but struggling to initiate or to follow through. This can create a cycle of shame and blame. Some parents need structure, others need flexibility. Yet most parenting advice assumes a neurotypical level of planning, memory, and time management. When we miss this, we risk layering guilt on top of genuine cognitive load. Sensory processing and overload. For many autistic and ADHD parents, the sensory world of early parenting can be intense and relentless. Crying, lights, smells, constant touch, it can all pile up quickly. Sleep deprivation makes it even harder to stay regulated. Yet parenting advice often ignores or even invalidates the need for sensory supports. When those needs are dismissed or pathologized, it can disrupt the parent's ability to stay present and connected in the relationship. Supporting sensory regulation isn't a bonus. It's foundational to bonding. So, overwhelm, meltdown, shutdowns, and autistic burnout. The early postpartum period brings a flood of demands: sensory, emotional, relational, and for neurodivergent parents, this can quickly lead to overwhelm. Shutdowns and meltdowns are not behavioural. They're signs that the nervous system is overloaded. They're often misunderstood or missed entirely. Autistic burnout is especially important to recognise. It's not depression, it's a chronic depletion. If we apply depression treatments like behavioural activation, we can unintentionally make things worse. Without the right support, these states don't just affect the parent, they shape the relational space with the baby. Intersecting physical health concerns. So many autistic and ADHD parents live with complex physical health conditions like chronic pain, fatigue, hypermobility, or immune issues. These are often dismissed or misdiagnosed, especially in women and gender diverse people. Postpartum intensifies these challenges. Sleep loss, hormonal shifts, and recovery demands make everything harder. Pain and exhaustion impact how a parent can co-regulate, how they tolerate touch, and how they care for their baby. When we invalidate or overlook this, we increase the emotional load and we reduce the connection between parent and baby. Neurodivergent care must hold both in mind and body together, not treat them as separate. And that's including for psychologists. Just going to have it to it. So I'd like to introduce you to Harper and baby Eli. And I've included this case study to bring these concepts to life. So Harper's story allows us to see what neurodiversity affirming care can look like in practice and how we can support regulation, identity, and connection by responding to the parent's unique sensory, cognitive, and emotional needs. It also highlights what can go wrong when these needs are misunderstood or dismissed. The goal is to help us move from theory into compassionate, practical care. So Harper, pronouns they, she, is a 33-year-old autistic and ADHD parent, recently identified, who gave birth to their first baby, Eli, 3 weeks ago. Harper was induced at 42 weeks, experienced a long labour, and is now recovering from a forceps-assisted delivery with a perineal trauma. In these early weeks, Harper finds themselves deeply in love with Eli, but struggling to stay regulated. The noise of Eli's crying pierces Harper's sensory threshold, and touch, even affectionate, can feel overwhelming, especially when combined with pain, poor sleep, and breastfeeding demands. They experience frequent shutdowns and episodes of emotional flooding that feel confusing and frightening. Harper's midwife suggests that it's postnatal depression, but Harper knows this doesn't fit. They feel emotionally connected to Eli, but physically and cognitively depleted. Executive function challenges make tracking feeds and appointments feel impossible without the shame. Attempts to follow standard feeding and sleep routines create more overwhelm. Well-meaning advice to get out of the house or stick to a schedule increases their burnout. Harper is also managing hypermobility-related joint pain, which limits their ability to baby wear or to comfortably breastfeed without assistance. They feel embarrassed bringing this up, fearing they'll be seen as too high maintenance. What Harper needs is not more advice and not behavioural activation. Harper needs nervous system informed, neurodiversity affirming, pain sensitive care that centres their capacity, protects their relational space with Eli, and scaffolds self-trust. So, how can we support Harper and baby Eli in the postpartum? First, affirming clinical support. So when we think about affirming clinical support for someone like Harper, it starts with co-regulation over fixing. Our presence matters more than our solutions. Instead of trying to correct or manage, we attune, helping Harper feel safe in their nervous system so they can co-regulate with Eli. We use consent-based language, offering choices rather than directives. For example, would it be helpful if, or is it okay if we explore this together? This builds trust. We offer sensory and emotional accommodations like low stimulation environments, time to process, validating shutdowns, and overwhelm as legitimate responses and not as problems to be solved. We centre validation of Harper's lived experience. That means believing them when they say something is hard and not needing to see it ourselves to take it seriously. We provide concrete, practical supports, visuals, step-by-step guidance, text-based communication, whatever works for their brain. We collaborate to find what fits. We don't assume what will help. We ask, we test, we adjust. Affirming care is flexible care because what works today might not work tomorrow. And the ability to adapt without judgment is a form of clinical attunement. So holding identity and bonding with compassion. This part of the journey is about holding space for both the parent's evolving identity and the unfolding of the parent-infant relationship. For neurodivergent parents like Harper, the early postpartum period often involves a deep reworking of self. Not just becoming a parent, but integrating that identity with who they've always been. That process can be tender, messy, and profound. Our role is to honour that evolution without rushing it. We also need to support co-regulation, starting with the parent's own nervous system. A dysregulated parent cannot access the relational cues needed for bonding. That's not a failure. It's a signal that more support is needed. Meeting needs for safety, processing, and connection looks like slowing down, being predictable, offering spaciousness for different communication styles, and holding a compassionate stance when shutdown or overwhelm shows up. And finally, we offer scaffolding, not solutions that assume a deficit, but support that affirms the parent's way of being. We collaborate, we adapt, and we provide gentle structure that helps the parent to feel held so that they can hold their baby in turn. So, how to support Harper and baby Eli in the postpartum, navigating an evolving sense of self. For Harper, like many neurodivergent parents, the early postpartum period is not just a life transition, it's an identity transformation. They're not only learning how to care for their baby, but also becoming someone new. This process is layered and often filled with both meaning and vulnerability. There can be grief, and this was raised in the chat yesterday. Grief for the loss of a previous self, for not fitting the parenting ideal, or for not having diversity affirming models to follow. Our role is to validate that uncertainty and emotion without pathologizing it. We use consent-based language to gently open space for reflection. Phrases like, "Would you like to talk about how this is feeling for you?" It helps build safety. We resist that urge to fix. It's easy to want to reassure or offer answers, but in this space, curiosity is more powerful than correction. We witness and reflect and hold space for Harper to define who they are becoming in their own way and in their own time. Supporting co-regulation of parent and baby. When we talk about co-regulation, we often focus on the baby, but it starts with the parent. For Harper, regulation doesn't come from knowing what to do. It comes from feeling supported, safe, and seen. Our first job is to support Harper's nervous system, not to just instruct them on how to soothe Eli. That means sensory accommodations. So the low light, quiet spaces, the rhythmic movement, and full permission to stim or to take breaks. These are essential. They're not just nice to haves. We also need to validate emotional states like overwhelm or shutdown. These are not parenting failures. They're physiological responses to a system that's under a severe load. And finally, we model attunement, not by taking over, but by offering presence. We're not stepping in to fix, to manage. We're showing Harper what it feels like to be regulated with. That's the foundation of co-regulation for both parent and baby. So for Harper to feel safe enough to connect with you and with their baby, they need communication that's clear, direct, and respectful of autonomy. That means no euphemisms or vague suggestions, just honest, consent-based dialogue. A question like, "Is anything in the room?" or "Is anything in your schedule feeling like it's too much right now?" That can open a door that neurodivergent parents often don't feel they're allowed to walk through. Give Harper space to process. Neurodivergent communication may come through silence, texts, visuals, or gestures. None of these are less valid than verbal fluency. And above all, validate Harper's experience and pacing, even if it doesn't match the typical trajectory. Just because something looks different does not mean it's wrong. It means we need to meet it differently. So scaffolding is most effective when it's both practical and respectful. For Harper, that means offering concrete supports, visual routines, text reminders, and flexible structure. Tools that meet their brain where it's at, not where we think it should be. It also means collaborating, not assuming. We don't decide what's helpful based on neurotypical norms. We ask, we test, and we define together. We stay flexible. What supports Harper this week might be too much or not enough for the next. That's not failure. That's life in a dynamic, developing parent-baby relationship. And finally, we must be careful not to confuse support with compliance. Affirming care is co-created. It's something we build with the parent, not something we deliver to them. So, reflective practice. This is my passion. We've covered a lot today. Sensory needs, shutdowns, identity shifts, and the relational heart of early parenting in neurodivergent families. Before we close, I invite you to pause and to reflect. What might shift in your practice from seeing early parenting in this way? What part of this changed how you see the kind of support neurodivergent parents actually need? Are there small adjustments in language or pace or expectations that you could make to better support autistic and ADHD parents in that tender early space? And finally, what language do you want to bring with you that tells the truth of this story more clearly, more gently, and more affirmingly? Because how we speak about early parenting shapes how we show up in it. So as we close, I want to leave you with this. Affirming care is not just a nice addition, it's transformative. When we recognise neurodivergent needs, respect neurodivergent rhythms, and reimagine what support can look like, we create space for real connection. It's not about fixing parents, it's about changing our standards. When difference is supported rather than erased, families don't just survive, they thrive. So thank you for being willing to step into this space with me today, with openness, with reflection, and a readiness to reimagine how we care. And the cringy last slide, if you would like to stay in touch, I love talking. Here are my contact details, which you can also see on the directory that Bronwyn spoke about. Thank you.
Amazing, Amy. Thank you. Take a breath, take a sip. Let's keep you in the hot seat for a little while because there are some wonderful comments that have come through and also some questions. Firstly, thank you for such a rich and important presentation, orienting us to some important points to consider in the postpartum. And thank you for modeling your pacing in this presentation too. It was really beautiful, so easy to listen to, and so many nuggets of gold in there. I was scribbling down some things thinking, oh, that's a nice way of saying it. And this is part of what we need as clinicians, isn't it? We need some language to grab hold of. It's so important. I mean, we talk about that a lot, you and I, Amy. So thank you for all of that. I love your note on co-regulation, and if it's difficult to co-regulate for the parent, you said that's not a failure, it is a cue that more support is needed. I mean, we could say that of anyone, but particularly our autistic and ADHD folk, right? So thank you for providing that little nugget of language. It's beautiful. I wonder, there's a few things I'd like you to speak more to, if I can pull your attention. First and foremost, For those who are new to the neurodiversity affirming paradigm, some of this might feel overwhelming. So I'm just speaking to those who are live or watching the playback and starting to think, gosh, there's a lot I need to learn and know here. And I also am speaking from that space, Amy, where clinicians can feel fearful of getting it wrong. And we don't want to cause harm to people, right? And so there can be trepidation for
Yeah.
clinicians who are starting to sort of make their way into this space and trying to hold the neurodiversity affirming lens. I wonder if you can suggest for those who are starting to integrate these ideas, where can they start? What should they do if they feel that they have put their foot in their mouth or they're getting it wrong? How does one correct? Because we know repair is so important within any relationship. Can you speak a little bit to that?
Yeah. I first as well, I just want to kind of point out that um, you'll hear me speaking today as if this is something I've always known. Um, and just to be very, very clear, I'm only 2.5 years or something post self-identification. So let's say 3 years ago, I was the psychologist that posted in the psych Facebook group going, surely this is all like misdiagnosis, overdiagnosis. All of my female clients are coming back getting diagnosed with ADHD. It's just anxiety. They're just like me. And I'm sharing that with you because, as I'm sure if you've done that recently, you might understand that I had a lot of, I'm going to say I copped a lot of flack. What I mean is it felt like it was flack at the time, but there was actually no disrespectful or harmful comments. But I was basically told, like, you know, get with the times. like there's a gap in what you understand and what is going on. And so I'm sharing that with you to say, I know what that feels like. And I
Mhm.
also know what it feels like to then to start to gradually, um, like clumsily, awkwardly trying to find my way towards affirming care and using non-affirming language. And again, today you saw me making a public statement about supporting our trans families. I'm still learning how to be more inclusive in my language. So it was conscious to use the word parent today instead of to say mother, for example.
Mhm.
So I guess what I'm trying to say is that, like, the truth is that we all have to start somewhere, and where you see us as presenters today is not where we started. Um, and it can feel really overwhelming to be learning how to unlearn. But I think what matters most is this ability to kind of, yeah, it's not even necessarily an ability. It's the willingness to kind of go, well, hold on, let me hear what these people are saying. Um, what what's that about? Like, to take your time and to kind of reflect and to listen and to stay open. And then if and when you get it wrong, I still get it wrong, right? If you get it wrong, then it's the showing up and doing the repair, as Bronwyn said. So it's acknowledging it, right? It's adjusting, it's continually showing up so that rupture, therapeutic rupture, doesn't become the defining experience for your client. Whereas when you
And
show up,
Amy, how would you say that? Can you give us some language about
yeah,
an example that you've used when there's been like a clunky moment and you've thought, oh, I've just missed it?
um, I'll give you an example that happened this week. All right, so
Mm-hmm.
it's nice and fresh.
Mm-hmm.
But with a perinatal client in a same-sex relationship, right? I went into the headspace of like trying to give an example, and my automatic internal process was heteronormative. And so I went with when the mother stays home and the father goes to work.
Mm-hmm.
All right. Now, that's not usually what I would do with that client, but what was happening was me trying to think creatively on the spot, on the fly, and naturally, especially because I'm an ADHDer, like that's hard work. So naturally, my brain relied on those automatic neural pathways, those automatic thought processes, those assumptions, those implicit biases that are already established. And so, thankfully, it's a client that this wasn't a new client. And I realized, and I said, I'm sorry. um, like let's change that. Let's
Mm-hmm.
go with the birthing mother who
Mm-hmm.
stays home with the baby, and with the mother who goes to work to earn the money, right?
Mm-hmm.
Which is fitting for their relationship. So anyway, that was this week,
So you
right?
caught it in the moment and just said, whoa, sorry, let's just have a redo.
Yep.
Yeah.
And
And off you went.
I saw in her eyes as I gave the example, I saw the recognition that I'd said the wrong thing.
Yeah.
But thankfully, this is how I roll in therapy. I've made
Yeah.
mistakes before and I've repaired with her. So although
Beautiful.
she saw it, um, she also was able to like roll with my mistake and move on as well.
Mm-hmm.
Yeah.
Mm-hmm. Mm-hmm. Beautiful, thank you. There was a comment that came through as you were talking saying, I am loving your honesty and vulnerability, Amy. Thank you for holding permission and space for vulnerability and not knowing to be present. Yeah,
Thank you.
yeah, of course. And I guess on that too, I picked up a quote that you said. I'm going to start quoting you, Amy. Our presence matters more than our solutions, which is a nice reminder as well. Amy, there are a couple of questions coming through on the chat. One of them, I just wanted to pick up about your note about depression and chronic depletion. So, making that differentiation, which is really part of our work in the postpartum now, right? That we might be looking at a classic depression or we might be looking at a chronic depletion that is more an autistic burnout. So holding that in mind, I wonder, do you want to say a couple of words to that? Do you want to spend any more time on that?
Um, so anecdotally, um, none of the clients, since I've at least felt more confident in understanding neurodivergence in the perinatal period, none of my clients who have been referred for postnatal depression, none of them that has been the answer. It's been that they are unidentified autistic ADHDers who have hit a autistic burnout or ADHD burnout
Yeah.
and have become depressed, right?
Yes.
But the depression is actually more to do with all of the ways that they have internalized neuronormative standards in how they're supposed to show up in parenting. So it's that feeling like a failure stuff.
Yes.
So again, I'm being very clear that that's based on my clinical experience.
Mm.
However, if I was to assume it was postnatal depression, um, I might be encouraging this parent to go and to join, like get out more with your baby. What things are on that you might go to? Are you going to mother's group? What about if we get you to I don't know, rhyme time with baby and so on. Go
Mm.
walking every day. Um, that is going to exacerbate the burnout
Yes.
because the burnout needs sensory accommodations,
Rest.
it needs rest, it
Yes.
needs people coming in and doing stuff so mum or dad can rest, so parent can rest. Do you see? I just did that then, guys. Do you see my automatic thinking there, mum and dad? Um, yeah, so I'm not saying that the depression can't be there, but it's like the depression is a symptom of the burnout. It's a symptom of internalized neuronormative standards or
Yeah.
neuro cisgender heteronormative standards, like all of that. Yeah.
Yes. Thanks, Amy. I just wanted to make sure that the message was landing around the difference in treatment approach for depression versus autistic burnout and how clinicians can inadvertently not help the depression or potentially make it worse if there is an autistic burnout sitting underneath fueling what's happening. So, yeah.
Could I
I've got,
just add just a sentence because I know you're
yes.
probably thinking, oh my God, Amy, time. So just a sentence on that. Um, I just want to be clear that if you're listening to this and you're thinking, oh, like I'm not sure, I don't know what that means. What am I supposed to do? Um, what I'm going to say to you is that these ideas are more about getting you thinking to think
Mhm.
differently about your clients. But
Right.
we all have to keep learning. So you need to like go away and keep learning. How do I support the autistic burnout instead of usual depression treatment? Yeah.
Hmm. Hmm. We're all in a learning space. Uh-huh. Um, there are lots of questions coming through, and we won't get to all of them, but I'm wondering if you can speak to this one because this is something that we talk about as well in group. Just wondering what to do if a parent doesn't identify yet, right? And may not be ready to acknowledge this, but the clinician suspects, so we think I think I'm sitting here with someone who is an ADHD or an ADHD or an autistic person, whatever. But there's a sense that this is not going to land for this person right here, right now, which is a clinical judgment, right? So it's great. This is a great question and great thinking in the mind of the person who's asked this question, because it's a therapeutic call in a way, isn't it? So, what are your suggestions for how to approach that? Uh,
Mhm.
yeah, and particularly if they are experiencing shutdowns, meltdowns in the context of the early postpartum period.
So first, I just want to model again and say it's taken a bit of learning to work out the whens.
Mhm.
And so I got it wrong a lot to start, as in
Yeah,
I said it too early, basically, that I
yeah,
thought that this was what was going on. What I've since learned is that I take it from the place of exploring with the client what their formulation is of what's going on for them. Um, but ultimately, neuroaffirming care, it's like regardless of someone's neurotype, it's based on us identifying what any person needs according to like how their brain works, how their body works, how their mind works. And so you don't have to use language like autism to start
yeah,
exploring sensory needs or to start exploring executive functioning challenges, right? Like um, a typical example, a client that is chronically late for appointments, Um, if we take that from a compassionate approach, we can kind of explore with them like what's making it hard to get to your appointments. Now, they might be an ADHDer who's struggling with all the things to get there. We don't need to call them an ADHDer to
Yeah.
find out what's getting in the way. And then our approach is, instead of holding our own ideas about what this should look like to get here, um, thinking about what's overwhelming for them. And so, in other words, maybe they need to have the 9 o'clock appointment with the reminder text message at 8 o'clock so that they can get out of the house and get here,
Yeah.
right? Is that clear?
Yeah, and I guess some of the part of the point too is that we don't have to label or bring attention to autism or ADHD, but rather we can still implement some of the scaffolding support which we might do for someone, whether or not they know or whether or not we're sure that they are autistic or ADHD, right? We can still get in there and provide the scaffolded support in a neuroaffirming way.
Yeah.
Yeah. Another question, please. Could Amy talk a little bit about what to do when folk hyper focus on babies' needs and forget about themselves to their detriment?
Mm-hmm. Um, I guess I would start by exploring what needs of the parents are not being met, because um, if we're talking about uh, not going to the toilet until they're busting, and feeling like they can't put baby down because they need to eat, but they haven't got anything prepared. They don't know what they want to have, and they can't put baby down because then baby is going to get upset. Um, Depending on what it is and how. So I'm thinking in terms of like those basic needs that we need to make sure get met,
Hmm.
as opposed to saying, maybe mum needs to spend half an hour de-stressing, right? Like
Yeah.
the way that I would respond.
Let's assume it's the basic needs, that this is a mama who is really struggling even to put baby down to go to the toilet or even to recognize I need to go to the bathroom.
Yeah. So if the mum is, or dad, parent is presenting with that kind of dysregulation that I would expect to see if they're not able to meet those needs,
Mm.
um, my approach is to find out like what's going on at home. Like, what are your days like? And
Mhm.
usually in that, they will start to talk about the way that they'll talk about baby is that everything is centered on baby, and that there's no space. So I'm looking for, when are you having your like lunch, or when are you um, getting your sleep, or like when what are you drinking water during the day,
Mhm.
So in exploring what their day is like, I'm asking those kind of direct, specific questions to find out where that stuff fits in, because those clients don't usually offer that information. They don't realize that it's important. um,
Exactly. So
and
part of it
then
is drawing their attention to it, right? So they might not even
yes,
realize that this is part of what's keeping them dysregulated. So as a
yeah,
clinician, asking those questions, even though they might seem quite obvious, you're suggesting that's a way in, right?
absolutely.
Yeah.
I still, if I'm hyper focusing and trying to get all the chores done at home,
Yeah.
as fully aware and as practiced in mindfulness, etc., as I am,
Yeah.
I still don't realize that I need to go to the toilet until my belly is hurting, right?
Yeah.
or until I'm starving hungry and like getting the shakes or whatever, right? So if I'm not noticing that with all of the skills and awareness and so on,
Yeah.
thinking about that parent with this baby, it's not surprising, right?
Yes.
Yeah.
Amy, in the service of time, I'm going to ask you to pause there. There are more questions and lots of beautiful comments in the chat for you. We'll go to our next speaker in a moment, but just to finish off and say, pick up on a comment. Such a beautiful presentation and so compassionately delivered. I could listen to you all day and then some. Thank you very much, Amy, for your presentation and also for answering those questions. Stay there. We're going to bring in Jilly now, but then there's a bit more Q&A at the end, so we'll see if there's some more time then. Otherwise, Amy will be in the meeting hub to answer questions directly after the session as well. Thanks, Amy. Let us move now to introducing our second speaker in this session. Gillian Ryan is a registered nurse, a midwife, an international board certified lactation consultant, and a late diagnosed neurodivergent woman. She's also a mum to 2 amazing kids. Based on Wadandi country in Busselton, Western Australia, Gillian currently works in a telehealth lactation consultant role, offering clinical breastfeeding, lactation, and infant feeding support to families across Western Australia. Today, Gillian is speaking with us about infant feeding support with a neurodivergent lens. Welcome, Gillian.
Thank you. Thanks so much for having me here. And wow, Amy, that was an amazing presentation, and you're very tricky to follow. And thank you for the introduction, Bronwyn. So I'll just wait for my clicker to click into gear. For my next slide to come through. Okay, I hope it doesn't go too far now. I clicked a few times. All right, seems good. So thank you so much for having me here today. I feel very honoured to have the opportunity to contribute to this very important conversation. My presentation is called Milky Vision, Reframing Lactation and Infant Feeding Support Through an Autistic and ADHD Lens toward a future of nervous system informed, affirming care for all families. And I'd also just like to begin by acknowledging the Wadandi people, the saltwater people, the custodians of this beautiful country that I'm very lucky to call home. I pay my respects to their elders past and present and extend that respect to any Aboriginal and Torres Strait Islander people joining us today. I recognise that First Nations peoples have been birthing, feeding and raising their children in community on these lands for tens of thousands of years, and I honour their deep and continuing connection to the lands, waters, spirits and all living things. As a health professional and parent supporter, I'm committed to learning from and standing alongside First Nations families and to supporting culturally safe, self-determined perinatal care. So just a little bit about me before we dive in. Before I became a midwife and lactation consultant, I followed a very non-linear path shaped, although I didn't know it then, by neurodivergence. In my early 20s, I started multiple degrees and trades and worked across industries like hospitality, media, mining, and more. I'd throw myself in and then pivot and start again. Then, when I was pregnant with my son, I met a midwife for the first time and knew instantly that's what I wanted to be when I grew up. I became deeply interested in birth, breastfeeding, and parenting, and I couldn't wait to be a mum. I had a very smooth pregnancy and a textbook birth and thought I had this motherhood gig in the bag. but postpartum hit me hard. I became a single parent and struggled with anxiety, depression, intrusive thoughts, extreme sleep deprivation, isolation, self-doubt, and a chronically unsettled baby. That experience opened my eyes to the enormous pressure on new parents in a world where isolation is the norm and where our capitalistic society pushes us to bounce back and function just as we did before birth. It also highlighted how the support offered by underfunded, overstretched, and disconnected systems often falls short. It also ignited a deep interest in postnatal care and maternal mental health. I became a nurse and then a midwife. But once I was inside the maternity care system, I saw how fragmented care, hospital politics, and time pressures made it hard to build the trusting relationships that I had imagined. I was also shocked by the lack of lactation education for midwives, and this later drove me to train as an IBCLC to offer families the support I knew they needed. A few years ago, my son went through a long period of intense school can't. After a confusing and traumatic few years, he was diagnosed with ADHD and autism. During that process, I recognised many of his traits in myself and eventually connected with a wonderful neuroaffirming psychologist who helped me to explore and embrace my own ADHD identity. That discovery changed everything. I began to see my entire life, including my early parenting experience, through a new lens. And I couldn't help but wonder, how different would motherhood have been if I'd understood my nervous system from the start? Rather than feeling like I was wrong and broken, maybe I would have had the tools I needed to cope, the language to describe my experience, and the voice to ask for support. Maybe I'd have had the self-compassion I so desperately needed, instead of blaming myself for motherhood feeling so hard. And I might have had the knowledge and confidence to support my son's beautifully sensitive nervous system instead of trying to conform to the rules and ideals that seem to work against us both. That question became a mission. Neurodivergence became my new special interest and soon merged with my passion for perinatal care and lactation support to become a kind of super spin. And that's what brings me here today, believing deeply that we can offer a different kind of care. Care that honours not just bodies and babies, but brains, nervous systems, and tender hearts too. Let's take a little sip of water. We won't go over all of the objectives listed on the slide. And similar to Amy, they're probably quite lofty, but I just wanted to put them all there and you can print them off and reflect back on those objectives later. And yeah, hopefully I'll help to meet some of those today. Okay, so lactation 101. I recognise that we're a diverse group of professionals in this conference, and lactation may not be your area of expertise or interest, but I do hope that you'll stick with me anyway, because even if lactation isn't your jam, you might be supporting a postnatal client who mentions something that we touch on today. And with a little foundational knowledge, you'll be better equipped to identify a potential challenge, validate someone's experience, or recognise when to refer to a lactation specialist. We don't have time to explore all the complexities of lactation, but here's a quick overview to sort of set the scene. So lactation begins well before birth. By around 16 weeks of pregnancy, breast tissue begins to develop and colostrum production starts. And the high progesterone levels during pregnancy inhibit the full milk production until after the baby and the placenta are born. So after the birth and the delivery of the placenta, progesterone levels drop sharply, which triggers the onset of copious milk production. And that's often described as milk coming in around day sort of 2, 3, 4, depending on birth interventions and complications. So the hormone prolactin supports ongoing milk production, while oxytocin enables milk to be released from the breast tissue by contracting the myoepithelial cells around the alveoli and pushing milk out towards the nipple. What's especially relevant today is that these hormones, and there are many more hormones involved in lactation, of course, but we'll just focus on these ones. Especially oxytocin is influenced by the state of the nervous system. Stress, pain, and emotional disconnection can inhibit oxytocin release and milk flow, and this can potentially reduce milk supply and lead to feeding challenges. And just a little bit more about lactation. So lactation works on a dynamic supply and demand system. Early stimulation and milk removal are vital for establishing a full milk supply. So each time milk is removed from the breast, prolactin is released to produce milk for the following feed. And in those early weeks, the more prolactin that is circulating, the more lactocytes or the milk-making cells are recruited and primed for production for the duration of the breastfeeding or lactation journey. And then on the flip side, if milk isn't regularly removed from the breast, we see an increase in concentration of a protein in the breast milk called feedback inhibitor of lactation. And when the concentration of this protein increases, this signals to the brain to slow down milk production. And if this happens continuously over time, this will lead to a decreased milk supply. I like the analogy of like hiring chefs to set up a huge commercial kitchen. So if enough orders, which is milk removals, come in early in the piece, the body will hire a full team of chefs, and the chefs are the lactocytes, the milk-making cells, to meet the demands of all of those orders. But if there aren't many orders coming in early, the body decides they can send those chefs home as they're not needed, and this will then limit milk production capacity later on. So early feeding support is really crucial, especially for neurodivergent parents who may face additional challenges. So today's focus is on lactation and breastfeeding, but I want to acknowledge that babies are fed in many different ways. We're all familiar with the benefits of breastfeeding, I'm sure, and that the World Health Organization recommends exclusive breastfeeding for 6 months and continued breastfeeding for 2 years and beyond, but not every family will follow that path. As an IBCLC, my role isn't to push any agenda, it's to support informed choices. I work with families who breastfeed, bottle feed, cup feed, use feeding tubes, donor milk, and a combination of human and artificial milks. What matters most is that families receive support and education that aligns with their values and needs. And importantly, I really want to ensure that the decision not to breastfeed or chest feed isn't due to misinformation, a lack of support, or systemic barriers. I also acknowledge that not all birthing or lactating people identify as women or mothers, and not everyone connects with the term breastfeeding. This is especially true within neurodivergent communities where we're more likely to meet parents who are outside the gender binary. So throughout this presentation, I'll use terms like lactation, breastfeeding, infant feeding, mother, woman, assigned female at birth, or AFAB, and parent somewhat interchangeably. I do this just to be clear and as brief as I can, but I do want to make sure that everyone knows that I honour all identities and no exclusion is ever intended. I'm always learning and I genuinely welcome feedback. Like Amy's discussion before, I think it's really important to be open and acknowledge that, yeah, I am still learning and I'm bound to say the wrong thing over and over again. And so if there's anything that you recognise that I could say or do differently or to be more inclusive, I truly appreciate hearing that feedback. This work is ongoing and I'm committed to always doing better. Okay, so to explore the common challenges often faced by autistic and ADHD parents during lactation, and I hope this doesn't sound like I've copied Amy, we actually had no idea what each other were doing, but I've also created a character and story, and this is drawn from a combination of lived experience, clinical observations, and current research. Our character in our story today was diagnosed with ADHD as a teenager, but like many AFAB folk, her autistic traits have gone unrecognised. The story today reflects standard maternity care in Australia. I want to acknowledge the many wonderful professionals like all of you here who are dedicated to learning and providing the best care possible. This story isn't about blaming individuals. It's about highlighting how fragmented care in a system that doesn't yet fully understand neurodivergent needs can lead to less than ideal outcomes for parents and babies. Parts of this story might feel heavy. That's intentional because this is the reality for many of our clients and sometimes for us too. Please stay with me. For every challenge, we'll return with insight, practical strategies, and ways you can help families feel seen, safe, and supported so that they and their babies can grow into happy, healthy, and confident humans. Have a little sip. Okay, so this is Addie. Addie is 34. She's pregnant with her first baby and lives in a regional Australian town. Like I said, she was diagnosed with ADHD as a teenager, but the focus was mainly on school performance. Her parents didn't want her to feel labelled, so they didn't talk about it much. She never received neuroaffirming support and didn't learn that ADHD could also impact her emotions, energy, and relationships, not just her academics. As she grew up, the diagnosis faded into the background. She kept taking her medication because it helped with work, but never connected it to other parts of her life. She often felt anxious. She was efficient, capable, detail focused, but now and then she'd crash. She'd miss a deadline, cancel everything, lie on the couch and scroll for days. She joked that she was a bit of a hot mess, called herself a control freak, laughed about her OCD tendencies, just like lots of women she knew. It felt normal. She didn't realise her ADHD hadn't gone away and that something else was going on too. Now that she's pregnant, she's stopped her stimulant medication, thinking it might harm the baby. At first, she felt fine. Maybe she had grown out of it, just like the doctor once said she would. But lately, things have been feeling a bit harder. She's planning to breastfeed and genuinely excited, but there's a quiet voice whispering, "What if I forget something? What if I get overwhelmed? What if I can't do it right?" She hasn't told anyone. She doesn't want to seem dramatic or ungrateful. She's not even sure her fears are valid. So she swallows them and masks and carries on because that's what she's always done. Maddie's care is shared between her GP and the public hospital. She's had a few brief appointments with midwives, mostly focused on screening tools, quick maternal and fetal checks, and data collection for her handheld record. At her first appointment, she mentions her ADHD history, but quickly reassures the midwife she's no longer taking medication. The midwife seems relieved about this and doesn't ask any further questions. At 30 weeks, Addie and her partner attend the hospital's group antenatal class. She's been really looking forward to this. She's deep dived into all things birth and hopes to connect with other parents. The class is held in a small, echoey room with bright lights and hard chairs arranged in a semicircle. Other couples are polite but keep to themselves. Addie doesn't get the chance to chat with anyone on more than a surface level, which she's a little bit sad about. The day is long and draining. By the time breastfeeding is covered, right at the end, it's clear everyone has switched off. Addie can't remember much of what was said. The handouts are black and white photocopies that look boring, so they get added to a growing pile of papers at home. She feels like she should have paid more attention to that part, but tries to reassure herself that breastfeeding will be straightforward so she can stop worrying. Addie is induced at 41 weeks for being post dates, goes on to miraculously have a spontaneous vaginal birth. Her baby boy is vigorous at birth and placed skin to skin on Addie's chest. Breastfeeding is initiated in the first hour with hands-on support from the midwife, but the latch feels pinchy and uncomfortable. In the days that follow, her baby feeds very frequently and only settles when he's being held. Addie's nipples are sore, she's unsure if he's getting enough milk, and she barely sleeps, no more than an hour at a time. Midwives offer latch support, but it feels rushed and inconsistent. Each shift brings a new midwife and different advice. I'll try this position. I'll bring him closer. Oh, it looks fine from here. Sometimes she's even corrected for using a position which another midwife recommended, which makes her feel ashamed and wrong. When she calls for help, it takes time for anyone to come. By then, her baby is screaming and won't latch. Other times, just as she settles him or she finally gets to rest, someone enters the room to do obs, clean, or collect trays. Addie is overwhelmed and feels wired. Everyone tells her something different, and she's not sure what she's supposed to be doing. She's sore, hungry, and constantly damp from sweat, blood, and milk. The hospital food is not appealing, and she doesn't feel she can shower as often as she needs due to the constant interruptions. She likes the closeness of breastfeeding. The weight of her baby on her chest is actually quite comforting, but her body aches from holding him. She wants help, but being touched by midwives feels intrusive. So she smiles and says it's fine, just to make them leave. No one considers whether she might benefit from a quieter sensory environment, repeated demonstrations, or clearer visual plans instead of constant options. What they don't see is that Addie's sympathetic nervous system is activated and she is in sensory overload. She's masking her distress, minimizing pain, and sliding into shutdown. But she doesn't speak up. She doesn't know how, or even if she's allowed to. She assumes this is just what new motherhood feels like. If she tries harder, surely it will get better. Addie and her baby are discharged on day 3. A midwife says, "You're doing great. Just keep feeding like you have been." Addie smiles and nods. At the car, she and her partner laugh, saying they can't believe the hospital is letting them take a brand new baby home without supervision. But beneath the laughter, Addie is terrified. Let's start with a common point of vulnerability: social and communication differences. Addie is intelligent and articulate. Like many autistic and ADHD folk, she struggles to keep up with conversations when she's tired or stressed. It's not that she's not listening, it just takes longer to process and integrate information. She also finds vague and metaphorical language confusing. Phrases like, "trust your instincts," or "he's feeding like a champ," feel really unclear. No one explains what they actually mean, especially when her baby cries constantly unless he's being held. Does that mean he's hungry all the time? She wonders. Addie hides her discomfort because she always has. She smiles and says she's fine, even when she's falling apart inside. She's highly sensitive to tone, facial expressions, and perceived disapproval. In hospital, she nervously asked if the pain during and after feeds was normal. A midwife stood over her and watched her feed, which felt intrusive. She was told the latch looked great. There was no nipple damage, and her baby's mouth looked normal, so it shouldn't be hurting. Addie internalized this as her being too sensitive. She's used to feeling like that. She's been told all her life that she is too much, and she knows it's her fault. She didn't ask again, assuming pain must be part of the breastfeeding. She doesn't want to be a burden. She worries about being judged or getting it wrong. Step-by-step written guides or quality visual resources she could process in her own time would help, but no one offers them or asks how she prefers to learn. And because she's unaware of her neurotype, she doesn't know she can ask for accommodations. When she tries to find answers online, the flood of conflicting information overwhelms her even more. She'd hoped to find connection at the new parents group, but after missing the first 2 weeks, the others had already bonded. The conversation stays surface level. No one talks about the hard stuff. She craves real connection and deep conversation, but it just doesn't happen. She tells herself the group just isn't for her. Another missed opportunity, not because she doesn't want connection, but because the structure and social norms don't support how her brain builds trust and safety. Wait for that slide. Have a little sip of water again. Now let's look at intersection of physical health and breastfeeding. Addie has postural orthostatic tachycardia syndrome. Oh, I really struggled with that. Postural orthostatic tachycardia syndrome, or POTS. During pregnancy, her symptoms eased a little bit, which is common with POTS, but postpartum, they're creeping back in. She feels dizzy, flushed, and has headaches, especially during feeds or when she gets up too quickly. Her cardiologist has advised against taking her POTS medication while breastfeeding, just in case. Addie doesn't want to risk harm to her baby, but she's scared she might faint while feeding. She hasn't showered in 2 days because that worsens her symptoms, but that makes her feel awful and stressed. Addie has always been very flexible. She can do some really good party tricks with her joints. No one suggested that she might have a connective tissue disorder like Ehlers-Danlos syndrome, which is often linked with POTS and neurodivergence. Now, breastfeeding is causing aching arms and burning wrists, but no one offers alternatives or supportive props to ease the load. She begins to feel sharp, burning nipple pain, especially between feeds or when she's cold. She does a quick online search and thinks that she might be experiencing vasospasm. She tries the home remedies, but the pain continues. Her GP mentions a medication that might help, but won't prescribe it due to concerns about her POTS. No one explores alternatives. They just give the advice, hopefully it'll get better with time. Once again, Addie is left navigating a siloed system when what she needs is collaborative, whole person care. Then something else begins. A sudden wave of deep sadness just before every feed or milk letdown. It disappears within a minute or two, but it's intense and awful. She starts to dread feeding. This is dysphoric milk ejection reflex, or DMER, caused by a sudden dopamine drop during the letdown. It's a neurological and hormonal reflex. It's not psychological. But Addie doesn't know this exists. All she knows is that something feels wrong, and she only has herself to blame. She begins to wonder if she has postnatal depression or maybe postpartum psychosis. She's in pain, exhausted, distressed, trying to understand her body while keeping her baby fed, but she hasn't been given the map to navigate this. What Addie needs is someone who sees beyond the latch, someone who can hold the whole picture and help her build a supportive, sustainable breastfeeding ecosystem. Most new parents experience some impact on executive functioning after the birth of their baby, like working memory, time management, emotional regulation, and decision making due to the fatigue, hormonal shifts, and neural changes. But for autistic and ADHD parents, these challenges are often intensified by pre existing executive functioning differences and a more sensitive nervous system. For Addie, the clash between her ADHD brain, which craves novelty and stimulation, and her autistic brain, which longs for structure and predictability, is exhausting. Before her baby was born, she thought she'd feed him on a schedule. Perfect. But once her baby arrived, she learned about feeding on demand. Now the schedule is useless. She's trying to track feeds in an app, but keeps forgetting to press stop, so now the data is meaningless. Suggestions like just go with the flow and sleep when baby sleeps only heighten her anxiety. She needs structure to feel safe. The routines she used to rely on are long gone and she doesn't know how to get them back. She can't seem to get into a state of flow like she used to when reading or doing something she enjoyed because the baby's needs are frequent and unpredictable. She's bored stuck at home, yet can't plan in advance to get out. Today, she'd decided to attend a local breastfeeding group. After weeks of hesitation, she finally felt ready. While trying to create a meal plan and a daily schedule in between feeding the baby, she lost track of time. Now she's late and decides not to go. The disappointment is heavy, but walking in late would feel worse. She's missed other opportunities too because of executive functioning challenges. She missed the first week of the new parents group because her reminder didn't go off in her phone, or maybe she was so tired she missed it. The next week, she got ready and left on time, but then took a wrong turn. When she arrived, the car park was full, it was raining, and panic set in. She circled the block a few times, couldn't figure out where to park, so gave up and drove home in tears. She was so mad with herself. She really wanted to go. Getting there just felt impossible. She's also forgetting to eat and drink. Her partner comes home to find she hasn't eaten all day, and then Addie feels guilty that dinner isn't sorted. She's been told, "Don't worry, your body will make milk no matter what." And while that's true to a point, her body is paying the cost. She's becoming nutritionally depleted, adding to her hormonal deficiencies and nervous system stress. She started pumping a little so her partner can help by giving an occasional bottle, but cleaning pump parts adds yet another barrier. She's constantly scrambling, always behind, and it's wearing down her confidence. Worst of all, she blames herself. Let's have a deeper look into Addie's sensory world. She's maxed out. Breastfeeding means constant physical contact, her baby's skin on hers, sticky patches of milk, unpredictable movement, and being touched all day and night. She loves her baby, but it's all too much. Her shirt clings to her damp skin. Breast pads shift and crinkle. Her bra feels like sandpaper. Even the click of her bra clasps grates on her. She's sweaty, milky, and can smell herself, and she hates it. The sound of her baby sucking and swallowing is hard to tolerate. The pump motor is worse, sharp, high pitched, inescapable. She feels trapped during feeds, holding still to maintain the latch, her limbs aching. Her eyes scan the room, but it's full of visual clutter. Laundry, bottles, receipts, dishes. No matter where she looks, her brain can't rest. She's bored and overstimulated at the same time, a unique kind of agony, and she doesn't know how to explain it without sounding dramatic. Her interoception is unreliable. She forgets to eat and drink, only noticing when she's dizzy or nauseous. Her body feels off, but she can't pinpoint why. She's been told her baby is likely overstimulated and should be fed in a dark, quiet room, but that feels oppressive, like a trap. And it doesn't work. He still won't sleep. Someone suggests taking him out more so he gets used to it. She tries going to the shops, but it's too bright, too loud, too many people. She ends up feeding him awkwardly in the car, changing him there too. Then she can smell the nappy the whole way home while he screams in the back seat. It takes the rest of the day to recover. She starts to wonder, maybe he's hungry. Maybe a formula bottle would help. She gives him a bottle of formula. He takes it easily. Over the next few days, she offers a few more. Over time, her breasts start to feel less full. Her baby gets fussier at the breast. Now she's worried. She reads online that she should pump more to boost her supply again. She tries, but pumping hurts and barely produces anything. The wearable pump that she has was okay for occasional use, but now her nipples are swollen and sore. The effort feels huge with little reward. She's stuck in a triple feeding vortex, spending nearly every moment breastfeeding, pumping, and bottle feeding. Add to that sterilising bottles, prepping formula, cleaning pump parts, all while trying to hold her baby so he doesn't cry. It's too much for any parent. But for Addie, it's unsustainable. Her sensory needs have never been acknowledged, not by the system and not even by herself. No one has ever explained that her nervous system processes the world differently. And now it's likely her baby is also neurodivergent. His sensory needs are intense. His sleep needs are low. He naps briefly when held, but never independently. Sleeping through the night feels like a distant dream. She's worried he'll fall behind developmentally if she can't figure out how to get him to self settle. The pressure is crushing. No one has ever told her that there's a wide range of normal for infant sleep, that falling asleep at the breast and needing to be held isn't a flaw, but a survival mechanism. She's trying to meet a standard she was never meant to meet. And instead of being given tools to understand and manage her experience, Addie is stuck in a kind of sensory tornado where the discomfort never ends and the internal whisper of, "You're failing," just keeps getting louder. By now, Addie's nervous system is running on empty. She's exhausted, touched out, overstimulated, undernourished, confused, and emotionally flooded. There's no time to process, no space to regroup, no map to follow. Her usual organisational strategies have collapsed. She's trying to follow conflicting lactation and sleep advice from professionals, forums, and well meaning relatives, but nothing seems to work. She loses track of the days, forgets to reply to simple messages, cries in the shower, then can't bring herself to shower again. She stops responding to texts from the child health nurse. Even the fridge calendar feels like a threat. She begins avoiding people, even the supportive ones. Friends call, but she lets it go to voicemail. She doesn't know how to explain the living hell she's in. Shutdowns become more frequent. Eventually, the calls stop, and she blames herself for being a bad friend. Other times, she spills into meltdown, rage, panic, tears, snapping at her partner. This isn't the version of herself she wants anyone to see, least of all her baby. Breastfeeding, once so important to her, now feels like just another demand that she can't meet. The pump sits across the room, almost judging her. Her baby's hunger cues feel like pressure. She's dreading every feed. She doesn't feel like she's producing enough, she's not resting enough, and not sure if she even wants to keep going. But she doesn't know how to stop either. And still, no one sees it, because on the outside, she's still saying, "Yeah, we're okay, just a bit tired." By 3 months postpartum, Addie is in deep burnout. The difference now, though, is that she can't just lie on the couch for 3 days and scroll. She has a tiny human to keep alive. What would happen if someone thought she wasn't capable of caring for him? Would he be taken away? She doesn't have the language or awareness that burnout even exists, so she just thinks she needs to try harder and do better. This didn't happen overnight. It's the cumulative effect of unmet and unidentified needs, invalidated instincts, sensory overwhelm, and invisible labour. More broadly, it's the result of gendered expectations, a culture that values productivity over connection, and fragmented, siloed healthcare system that fails to see people as whole. No one was there to look at the big picture. No one helped Addie understand how her nervous system works or what she needs to thrive as a parent. She never connected with other autistic or ADHD parents before birth, so there was no one to catch her on the other side. No one to say, "You're not broken, you're not alone, we see you." She felt isolated, misunderstood, and heartbreakingly believed it was all her fault. This is what happens when care plans focus on tasks and tick boxes instead of individual needs, capacities, and context. When services assume parenting struggles like missed appointments, non attendance at groups, and more seriously, baby's growth faltering are due to non compliance, instead of asking, "What can we do differently to fully support this parent baby dyad in front of us?" That was heavy. We've just walked through part of Addie's breastfeeding journey, one that reflects the all too common experience of missed needs, misunderstood behaviours, and siloed care. But that's not where the story has to end. What if Addie's neurotype had been named, supported, even celebrated? What if her sensory needs, communication style, and emotional landscape were seen as valid, worthy of accommodation, not correction? What if her care providers had worked with her to co create a feeding and parenting experience that honoured her strengths and supported her challenges? In the next section, we'll revisit the 5 challenge areas and reimagine how Addie's story could have unfolded with the right support. We'll look at a range of strategies and accommodations. Some are big picture changes that require systemic shifts, but many are small, practical things that you can implement today or share within your networks to plant seeds of change. This isn't an exhaustive list. Just as there are many ways to be human and to be neurodivergent, there are many pathways to feel supported. What matters most is approaching each client, dyad, and family with curiosity, compassion, and an openness to do things differently. When we offer care that's truly individualised and affirming, we empower parents to embrace their neurotype, unmask when it feels safe, and welcome the accommodations that will help them thrive. How are we going for time? I will try and whiz through as quickly as I can, Bron. I know where I'm getting to that point. So thinking about communication, we can start by asking every client, how do you prefer to receive information? Would they like things written down, voice notes, short videos, diagrams, step-by-step instructions with pictures? And also ask how each client prefers to communicate. Do they use writing, speech, an augmentative and assistive communication device? Do they prefer texts, phone calls, emails, or voice messages? So if we introduce this as a standard of asking everyone, then we don't need to worry about who is identified as neurodivergent and who is not. We are going to be capturing everyone. And also explicitly say out loud, or just take a sip, say out loud to everyone that you're welcome to communicate in any way that works for you. Text, email, voice note, whatever feels easiest. And if that changes depending on how you're feeling, that's okay too. This kind of permission can be a huge relief for clients who are used to masking confusion or distress. Oops. So, what happens before the appointment matters. So, if we're looking at lactation, for example, um, where before you see a client, you would most likely send an intake form. And we just want to make sure that all of those forms, so whether it's for whatever initial appointment in whatever profession we're talking about, including ADHD, autism, and sensory needs on the intake form, and make them as visible and important as other health conditions like asthma or previous surgery. And by doing this, we're sending a powerful message that your brain matters here and your nervous system matters here. Even undiagnosed or unidentified clients may feel seen if you invite them to share sensory sensitivities. And we can think about putting this in a similar section to medication allergies or food allergies. Because really, if we think about it, we want to make sure that we are thinking about these sensory sensitivities, because if people are exposed to those sensory inputs that are damaging to their nervous system, then we are going to have detrimental physical and emotional responses. So you can offer body-based prompts like, do you have any sensitivities to light, sound, texture, smell, temperature, pain, movement? And then add space for clients to describe what this means for them and what strategies or accommodations they already use to make daily life more easeful. This isn't just a tick box exercise, it's an invitation for deeper understanding that can guide truly personalised care. Mm, So, talking about how we can build relational safety, first, it's very important to mention consent. So, let's always just ensure that we gain informed consent in this space, and especially if body contact with either the parent or the baby is indicated for a physical assessment. In lactation, we generally don't need to be touching parents' bodies. I work in telehealth, and there's no way that I can have any contact with a parent's body, and we are still able to talk about changes to body position or implement ideas without even being in the same room. Recognizing that masking is common, especially in healthcare. Um, so we can just let clients know if it's ever hard to talk about something out loud, but there's something that you need to express, feel free to write it down on a piece of paper or message me. You don't need to explain why. Be mindful of rejection sensitivity dysphoria. Addie experienced that in the story. So just at all times, if we can, be warm, genuine, and kind to all people. Many neurodivergent people carry a lifetime of shame from feeling misunderstood or wrong, and we want new parents entering this season of life to feel confident and valued. So, peer connection is really powerful. powerful, excuse me, when we see our experience reflected in other people's stories, we feel seen and safe. I love the quote, "Shame dies when stories are told in safe places," by Anne Voskamp. Excuse me. So just whenever we can, if we are in a position to facilitate neurodivergent connection or point people in the direction of where they might be able to find that kind of space, that's going to, excuse me, help support them to feel less alone. And ask all people if they have any special interests. Talking about a spin can really help the nervous system to settle. This can be a beautiful tool for connecting. We want to celebrate people's special interests. Often we see breastfeeding and lactation and birth become special interests for new parents. But whatever it is, celebrate it and make connecting over special interests a part of your care. And finally, honour diverse ways of bonding with babies. So eye contact isn't the only way. We often see, those idealized pictures of parents breastfeeding and gazing into their baby's eyes, but that can feel overwhelming and too much and very uncomfortable for some people and for some babies. So let clients know that talking, singing, or simply sharing what they love with their baby during feeds is a way of connecting as well. So recognising and supporting physical health concerns. So neurodivergent parents are more likely to experience chronic conditions that can impact feeding, stamina, safety, and comfort, like Ehlers-Danlos syndrome, POTS, edema, chronic pain, GI issues. So I'll just briefly go over some strategies to support them. So with breastfeeding positions, kind of think outside the box. We don't need to default to the cradle and cross cradle holds. Try laid back positions. Side lying positions are wonderful because the body the parent's body is really well supported and they're not needing to support the weight of the baby as well. Or upright feeding positions for baby, like a koala hold. Use pillows, neck supports even, and footstools to reduce strain. There's so many different schools of thought with lactation, and some people will say, no, don't use pillows, it interferes with positioning. But really, we just need to look at each client, each person as an individual and work out what their body needs to enable them to feel supported so that they can support their baby. A baby wearing consult might be a game changer for learning to feed in a carrier. I know that that's not accessible to all, and baby wearing might not be comfortable for someone that does experience pain or hypermobility, but it's just something to consider. And ask what feels physically sustainable for you. So look at the whole body, not just the latch. I think it's really, important for hypermobile clients to think about their neck. If they've got hyperextension of the neck, that can trigger a POTS reaction as it sort of triggers the vagus nerve. So thinking about, maybe using a travel neck pillow to support the neck, or a squishmallow maybe around the head so that they can pop their head on while they're feeding. And if a client is sitting in an unconventional position while they're feeding, say, for example, they've got a leg tucked under their body, that it might not look comfortable to you, but it may actually be a self-regulation strategy. They're engaging deep pressure by, like in their muscle groups, by using their leg for that. So just observe with curiosity, not correction. If pain and fatigue is an issue, we can refer to physios or OTs, especially for joint pain and hypermobility. And there's public pathways for referral in all states, I'm sure. And then thinking about for clients that may have NDIS funding, depending on if they have a formal diagnosis of a disability, just checking in and seeing if they do have funding available for OT or physio that might be available to be used to help them with their feeding experience. Keeping in mind interoception differences that might blunt pain signals. Alexithymia, I know Sarah mentioned alexithymia yesterday. So that can make it difficult for clients to describe the sensations that they're feeling. And many clients have a history of being dismissed by the medical system, so they might underreport. In terms of understanding the sensory experience and if there is any pain for a client, thinking about using a pain assessment tool that is more than just the sliding 0 to 10 scale. So a good one is the McGill Pain Questionnaire. So it goes beyond just 0 to 10. It incorporates sensory descriptors like, is the pain sharp, prickling, or soggy? Emotional impact of the pain or discomfort. So, and it lists words like annoying or torturing, and also asks for the client to rate the functional implications of the pain or discomfort. And this information can help us to get a better understanding of what might be happening, what we might be able to suggest as a strategy, and then to track what's working and what's not. And importantly, medication advice is frequently outdated. So, so many medical practitioners are very reluctant to give prescriptions or, recommend breastfeeding or lactating parents take medications for different medical conditions because there is a fear of that medication being transferred to the baby. But actually, very few medications are contraindicated in breastfeeding and lactation. There's a couple of great resources that clients and clinicians can contact to find out about the safety of a particular medication. So in WA, we have the King Edward Memorial Hospital pharmacy that we can call, and actually everyone Australia-wide can contact Rodney White. I think he works out of Monash in Victoria. He is a wonderful specialist perinatal pharmacist, and he is an absolute font of knowledge when it comes to medication. So it's definitely worth, if a client comes and has a medical condition and they say, oh, I'm not taking my medication for that because, I'm worried about the baby, or the doctor said it's not safe for the baby, just make sure that they have actually checked with one of those specialist pharmacists, because it might actually be the case that they can safely take that medication. Of course, that's up to the client to decide if they do want to take that medication, but even in the case of ADHD stimulant medication, it is highly possible that they can take that medication safely. Oops, I think I might have just scrolled. Where did we go? I got fidgety and I scrolled with my scrolling wheel. Okay, here we go. So briefly touching on another experience that Addie had in the story. She was experiencing dysphoric milk ejection reflex, or DMER. So this is not a mood disorder. It's caused by a dopamine drop just before the milk letdown. And for some, especially those with ADHD, it feels like a sudden wave of sadness, dread, or anxiety that lasts for a minute or two, and it can be incredibly distressing. If a client is experiencing this, just naming it can bring relief. We don't have a lot of treatment options for this at the moment, but there is emerging research. You can just say, we're still learning about this condition. You're not alone. It has a name. This is what it is. It's about brain chemistry. It's not about your bond with your baby. And referring clients to d-mer.org. They have great parent-friendly explanation and lived experience stories there. Sorry, Bron, I know I'm going over. So I will be brief. So putting the function back in executive functioning. There's quite a few strategies listed on the slide there, but I think importantly, just sort of giving permission for parents to, do something that they enjoy while they're feeding. If they're bored, so watching a favourite show, listening to a podcast, playing a game on their phone, whatever it is that they want to do. thinking about building daily rhythms instead of rigid routines. For example, after the first daylight feed, we can open the blinds, change our clothes and brush our teeth. During the mid-morning nap, if baby does have a sort of a round mid-morning nap, that's when we can think about pulling dinner from the freezer or doing a quick shopping list. Stacking self-care onto baby care. So every time I feed the baby, I'll sip water and have a snack. Make eating and drinking easy. So making sure that, and this is where partners and supporters can help with having high nutrient snacks prepared and ready to go in easy grab packs in the fridge, and making sure that we've got water bottles at each feeding spot throughout the house so that when the parent sits down to feed, they can be nourishing themselves as well. Unburden the brain. So just supporting with practical tools that reduce executive burden, making sure that we're providing clear written and visual information for appointments, such as when you come to this appointment at the hospital, this is where to park. The door that you walk through is blue. You'll go to the reception, which is on the left. If you ask for, insert whatever name, and also giving some information about what the appointment will look like, just to remove any of the uncertainty that can bring anxiety. And offer logistical tips like using open, clearly labelled baskets on the bench for pump parts and bottles, so that there's just a system. Once pump parts are washed, everything can go back in that basket ready for next time. Breastfeeding and chest feeding is a full body sensory experience. Jenny Stiller, who's an IBCLC who specialises in neurodivergence, notes that there's over 40 sensory inputs in a single breastfeeding session. If someone is exclusively breastfeeding for a year or for 6 months and then up to feeding the baby continuously for that year, that's more than 1,800 hours of feeding in the first year, which is the equivalent of a full-time job. So little sensory strategies we can use. If light touch is irritating to the parent, they can just hold onto the baby's hands. Babies can be very feathery, strokery, so we can just hold the baby's hands really close and sort of set that boundary that that's where you would like their hands. If skin to skin feels too intense, use a soft wrap or cloth barrier between parent and baby. Encourage using sensory tools like ear defenders or noise cancelling headphones, wearing sunglasses inside if it's bright, or dimming the lighting, having a fan on to help with the noise and to give some cool air. Encourage stimming, use fidget toys, have soft textures available nearby, whatever it is that is going to make that parent feel regulated. Reducing visual clutter, so just draping a cloth over laundry or dishes if the feeding area is in that zone, and maybe trying to preserve one calm zone in the house that's a no junk area where the parent can go to know that they're going to have a visually pleasant area for regulated feeding time. And if they like, we can take feeding outside for a sensory reset.
Jilly, you might need to move now to your final slide because we'll need to finish up the session in a moment.
Thanks, Bron. I will move on. Everyone can access these slides, so you can go through the strategies in there. Excuse me. So I would like to finish by, just saying that we don't need to overhaul the whole system overnight. If we all walk away with one small shift, a new question on an intake form, a sensory-friendly tweak to our clinics, a more thoughtful response to distress, the ripple effects will be huge. Start by listening to and trusting our clients, and let's offer care that supports their nervous system, not just their nipples. Because when we do that, we can change everything. And finally, neurodivergent, autistic and ADHD parents deserve, just on that last slide there, to feel safe, not judged, to have their needs seen and met, to feed their babies with confidence, and to feel like they're not alone. And yeah, right now, so many autistic and ADHD parents, especially those who are unidentified or undisclosed, are falling through the cracks. So that means we as health professionals must apply the lens we've explored today to every client, not just those with formal diagnoses. By weaving nervous system informed, neurodivergent friendly approaches into our standard care, we make our safe spaces safer and more supportive for everyone. And that's it.
Jilly,
Thank
thank
you.
you. Let's pause it. There's a great note to end on. Thank you so much. You don't know this because you haven't kept your eye on the chat, but there's been a lot of chat, a lot of beautiful comments coming through about how much people have enjoyed this presentation. Thank you for delivering it with your characteristic sensitivity and compassion. Such great modeling there for all of us. I'll just read one comment, which is, honestly, Gillian, what a divine presentation of a case from the inside out. Magnificent, poetic. Thank you so much. Right now, we're going to go straight into the polls. Nikki, if you will launch those polls for those who are still with us live. If you were here yesterday, you know the drill. If you weren't, here's the lowdown. This is anonymous. Up on your screen now are 4 questions, 2 for each presentation, and there are 4 options to choose for each one. If you can have a look at that poll now, you don't have to participate, but we would love your feedback. I can see some of the data coming through now. Well done. Thank you for participating. And I'll just allow another minute for those who are wanting to participate in the poll. And lots of great comments coming through for you, Jilly. Beautiful presentation. Thank you. Loved the case study. Thank you so much, Gillian. This is amazing and so well thought through. Such a beautiful presentation. Just another moment in the poll. Give you another 30 seconds before we close that off. All right, let's close that there, Nikki. Thank you, everyone, for participating. We'll end the poll and we'll share the results. You can have a look at that for those of you who are live. And if you're still with us, we would love you to give some feedback and to help you to consolidate your learning. Here is a reflective prompt on the next slide. There we go. Identify one thing that has caught your attention from the content of this session. That's from either Gillian's presentation or Amy's presentation. Identify one thing that caught your attention from the content of this session. What do you really want to hold on to from today? Let us know in the chat. What is one thing that caught your attention from the content of this session? Remembering to think about comorbidities. Yeah. What a fantastic morning. So much information to take away and to tweak my practice. Yeah. It is okay to still be learning this, to admit that, and to admit that to patients, right? To make mistakes, to repair, just hold space and be curious, ask what they need. Yeah, I like the little quote, observe with curiosity, not connection, right? Shutdowns and meltdowns are not failures of a neurodivergent parent, but indicators of a nervous system that is overwhelmed. Yeah, beautiful, beautiful take home. And maybe some more comments coming through. For those of you who can stay with us live, then feel free to keep going, popping things in the comments. For now, I'm going to conclude this session and we'll end there. We have those of you who are live with us, we now have a break. You can jump back into the virtual meeting hub now if you want to. And you can speak with the presenters. They may be able to answer some of your questions there, but do decompress and rehydrate and have some lunch, and then join us back for our second session today. We'll be starting promptly on the hour. Okay, thank you. Bye for now. Bye.